Hi there. I think we're live. I'm Dr. Virginia Steen. I'm at Georgetown University, and I'm pleased to talk to you today about scleroderma in African Americans. I came to Georgetown about 25 years ago, just as the foundation was starting, and the African American population in Georgetown in Washington, D.C. is a whole lot more than where I was at the University of Pittsburgh. And so I've had a lot of experience learning how scleroderma is different in African Americans. And so what we're going to talk about today is the frequency and the outcomes of scleroderma in African Americans. We're going to talk specifically about clinical features and major problems that are, even though they're the same scleroderma features, they're either more severe or they occur at different times. And then we're going to talk a little bit about why the possible reasons these differences may occur. Next. So years ago, I did this study looking at the incidence by race, age, and sex of scleroderma. And these are the women, and the Black females, you can see, have a, have a higher frequency, both in much earlier age, as well as even the usual mid-age patients, but it's even earlier than the white Caucasians. And interestingly, the Black men have even a much higher frequency than the white men. Again, much earlier peak and occurring in much earlier disease age range. Next. So this is the prognosis. This is a mortality rate, and the red bars are those in African Americans, and the yellows are in Caucasians. And you can see in both females and in males, there's a worse prognosis in this population. Next. And when I did a study, particularly looking at African Americans versus Caucasians in my Georgetown population, which we match. So many times you include a lot of everybody together, and you end up having more severe disease just because of the type of disease that patients that are African Americans have. But we specifically matched for disease duration, for diffuse scleroderma, for the age of the patient, and we still found that there was a higher, there was a decreased survival, as you can see from these lines, compared in the African Americans compared to the Caucasians, and that was statistically significant. We went on to do some more fancy statistics, and we were able to show that there was some correlation with socioeconomic status, but my population of African Americans are working class people. There are not a lot of indigent people, but it still was by zip code, their socioeconomic cost of what their salary was less. And that did have some statistics, not just in African Americans, but also in the non-African Americans. So socioeconomic status, again, not specifically for African Americans, did correlate with survival in this patient population. Next. So the presentation, what I learned very early on, that the presentation of scleroderma in African Americans is really a bit different. Many patients will have very non-specific symptoms. They have joint pains, and they usually, as all scleroderma patients have a positive ANA. So frequently, they're diagnosed initially with lupus. When we recently looked at our African Americans versus Caucasian patients, up to 15% of scleroderma patients that were African American had been diagnosed previously with lupus, even though they never really reached criteria. So initially, they were treated with Plaquenil, which may help the joints, but it really doesn't do much of anything else for scleroderma. And then it led to often to a delay in the diagnosis of scleroderma, and particularly some of the other problems that could have been treated, particularly lung disease, as you'll see. Next. So Raynaud's is also a little bit different and harder to recognize for African Americans. It's less common as the first symptom, and generally it presents with sort of, they feel their hands are cold, but they don't recognize the white changes or the purple changes. However, they do notice, and they're very sensitive to the fact that the pigment changes are often very common. We had a patient yesterday where the pigment changes in her hands were significantly darker than in the rest of her skin. And she hadn't noticed that. And I asked her about it. And she says, oh, now that I think about it, my skin is much darker on my hands. But I've had patients that volunteer that. And we think that that has a relationship to the inflammatory process that's going on in the hands and the swelling in the hands. And so that's often the first symptom. Skin thickening in African Americans is usually diffuse, but it's maybe not quite as severe and not quite as much of a problem as Caucasians, but it certainly is a major problem. Next. Whoa, you went through a lot. Okay, so here are just some of these typical pigment changes. You can see, I don't have a pointer, but you can see the hypopigmentation on this lady's chest, and on the hypopigmentation on the arms and the hands. These are very classic findings that we see in patients of color. Next. So again, you can have increased pigment and decreased pigment, and many of these are really quite bothersome to many patients. Next. So we did a study about 10 years ago with actually Dr. Jessica Gordon, who is at HSS now, led this study, and we asked both Caucasians and African Americans what they felt about different images that they have. And there were both groups of patients were, moderately distressed by this, but it was particularly prominent in African Americans that had moderate to severe distress as opposed to mild distress. Next. So the things that African Americans were more distressed by than Caucasians were the severity of the digital ulcers, and they do tend to have more ulcers. And interestingly, much more bothered by the dark pigment and the white pigment. So as opposed to the Caucasians here, they were mostly bothered by the wrinkles above the upper lip, and really were not bothered by the dark pigment and the white pigment. And actually, many of our patients that are Caucasians like having increased pigmentation because they look like they have a tan all the time. Equally bothered by the amount of skin thickening in both groups, though. Next. So these are back. Okay, so these are the salt and pepper skin changes and the pigmentation changes. This has this long fancy name called Scleroderma, but basically because the skin has melena, which is the pigment changes, and that is affected by scleroderma, and not necessarily just when there is skin thickening, but it can also happen just because there's scleroderma present, and that causes these changes. Next. Unfortunately, we don't have a lot to do for the treatments of this discoloration. The most important thing is sun protection, because the melena that's in there is very sensitive to the sun, and so you really need to use sun protection. Retinoids and hydroquinone and some newer treatments are possible, but none of them are really that effective. Next. So we encourage avoiding sun exposure, particularly during peak hours of sun, using some protective clothing and hats, and making sure that when you use sunscreen, you use better protection with the wide spectrum greater than 30, particularly for patients that are more likely to get more sun exposure. Next. So there are retinoids, which are vitamin A derivative medications. They're only available by prescription, although there is a a retinol formulation over the counter, but it really hasn't been very effective. And it changes the skin pigment by improving the cell turnover. So the natural history of the skin coloration really is changes over time. And in many cases, the darker pigments become lighter and the lighter pigments become darker as the disease evolves. And so it does change over time. The problem with the retinoids is it causes a lot of dryness, which always occurs anyway in scleroderma. So it sometimes can be very bothersome. So you need to use it sparingly. Next. So there is this bleaching cream called hydroquinone. It actually turns off an enzyme called tyrosinase that makes the pigment. And you have to use this with sun protection. It is available by over the counter as well as prescription. But to be honest, I really, even though I work with a wonderful dermatologist and she's tried to use this in some of our patients that we work together with, it really has not been a wonderful option. Next. So the next part of this is a study that I did now 10 years ago with the data from the patients when I was at the University of Pittsburgh. And it took us 10 years to get a total of 202 patients. Actually, it was 20 years to get 202 African Americans. And we compared this to the Caucasians. They were, as usual, mostly female. But look at the age. The onset of age is much younger than the Caucasians, and more of the patients had diffuse scleroderma. And so we're going to go through some of the organ involvement that we found in comparison in this patient population. Next. So we had definitions of severe organ involvement. This isn't just any organ involvement. This is severe. And so severe for skin involvement was diffuse scleroderma. And as you see, 26% versus 25%. Again, similar in both those groups. But muscle involvement, inflammation and fibrotic was more common in African American. GI was more common. Pulmonary fibrosis was very significantly more common than Caucasians. Interesting, these less common problems were pretty much the same. Pulmonary arterial hypertension, heart, and kidney were similar frequencies in the African Americans versus the Caucasians. Next. So the muscle involvement in African Americans can be three different types. You can have the typical inflammatory overlap with inflammatory myositis, which causes a very elevated CPK, which is the muscle enzyme, creatine phosphokinase. And that will cause really quite severe and acute proximal weakness. And this definitely needs treatment with steroids. And this is often present when somebody has an overlap with other diseases like scleroderma and rheumatoid arthritis and lupus, and associated with the antibody U1-RNP called mixed connective tissue disease. And I talked with some of you with that last year. So there's another type of muscle involvement that we see fairly common in African Americans. It's a mild elevation in their CPK. They have a mild weakness. But when we look at it with biopsies or other things, it's more of a fibrotic weakness, fibrosis, like skin thickening in the muscles, scar tissue in the muscle, and it leads often to contractures. And so the biggest treatment for that group is really early aggressive exercise, particularly involving the shoulders, because many times the shoulders get very contracted and patients can't raise their arms up. We do use some low-dose prednisone to try to help with the little bit of inflammation that can happen. And also you can have muscle involvement that only has the elevation in CPK. African Americans, independent of scleroderma, frequently will have elevations in their CPK. Not that we really totally understand why, but it doesn't occur with any weakness. So it's important to recognize if you have an elevation in your CPK, it doesn't necessarily mean that you're going to have severe weakness or anything. Next. So the treatment, as I talked about, is exercise, range of motion, strengthening, particularly in the arms and the shoulders, use of anti-inflammatory or pain medication, because sometimes these contractures are painful and you need to have some relief while you're doing the exercises. We also really encourage all our patients to do walking to improve their endurance and their exercise capacity. And cardiopulmonary exercise is really important as well. And they are really becoming very important, particularly if you also have heart or lung involvement. Next. So GI and small bowel symptoms. So GI are some of the most unrelenting symptoms that all of our scleroderma patients have. But it seems like both in my last study recently in the scleroderma patient population from Georgetown, as well as my initial study from Pittsburgh, that there's more small bowel involvement that really can be very refractory to treatment. And these symptoms are, in many patients, nausea, bloating, feeling full, having vomiting, diarrhea. You can get severe malabsorption, weight loss, as well as constipation. And these are all involving the entire GI tract. And I know we've had some really excellent talks, one, I think, by Dr. Liz Volkman that talked about the GI problems, but it does seem to be more severe in African Americans. Next. So the small bowel involvement leads to dilation of the small intestines, and these are just X-ray pictures that show this distension of the small bowel. But what you as a patient will feel is really that your abdomen is really bloated, that you may feel like you're 6 or 8 months pregnant because it's so distended. And this is really uncomfortable, sometimes causing diarrhea, sometimes vomiting, sometimes constipation. Next. So we have lots of treatments, but nothing is specific for scleroderma. So we have lots of treatments for the reflux and the heartburn. And I'm sure Dr. Volkman went over that, using prevention, not eating before going to bed, head of bed elevation, the proton pump inhibitors, the H2 blockers, the Myelantin-Maalox type of protection, the bloating and distension. Sometimes probiotics are helpful. And then the diarrhea, which may be related to small bowel involvement with bacterial overgrowth, in which we have to use antibiotics. And then constipation, initially maybe with fiber or Miralax, but there are now some motility drugs that affect the constipation. I think we've had particularly good luck with prucalopride or Motegrity, which may affect more than the colon, but at least it's approved for constipation in anybody. So perhaps that would be a good drug for patients that have constipation and scleroderma. Next. Next. So lung disease is really one of the major causes of death in all scleroderma patients. And this, as you can see, pulmonary fibrosis. This is from really one of my landmark studies out of the University of Pittsburgh back now many years ago, but it still has held true with all more recent studies that both pulmonary fibrosis and pulmonary arterial hypertension are the major causes of death in our patients. Next. So the risk factors for severe fibrosis occurs most commonly in early disease and diffuse disease, and with autoantibodies, particularly the anti-SCL70 or the nucleolar ANA antibody. And these are antibodies, as you'll hear a little bit later, that are more common in African Americans. And not surprisingly, it's more common in African American. You all know about pulmonary function tests. And so when you have a pulmonary function test early in your disease and you have an abnormal FVC, that means you're at very high risk for having progressive interstitial lung disease. Or if you're managing your PFTs carefully and monitoring them, and your FVC decreases by 10% of the volume, not 10% predicted, but by 10% of actually the the amount of volume that the forced vital capacity reflects, that's a bad risk factor. We like to make the diagnosis of interstitial lung disease long before patients have significant symptoms, but certainly if you develop shortness of breath with exercise, particularly, this is not like asthma that happens anytime and you get shortness of breath anytime or at night. This is mostly early on with exercise, as well as a cough. And of course, cough can be from many things in scleroderma, but these are things you should really pay close attention to and tell your doctor as soon as you notice that there's a change in your symptom complex. Next. So this is, again, another study I did early on, which showed that the change in the forced vital capacity in patients who eventually developed severe lung disease was mostly in the first 5 years. This is years, and this is amount of volume that they lost. And so many of these patients were totally asymptomatic during this period of time, and yet they lost most of their volume during this first 5 years. And so that's why we're really careful about trying to identify and aggressively treat patients early on. Yes, they continue to lose volume as time goes on, but once you've lost a lot of volume, it's much harder to improve that volume. Next. So sometimes it's hard to recognize, and that's why it's really important for you to pay attention to. We talked about how shortness of breath is mostly with exertion, but you may only feel fatigue when you exercise, and fatigue may be your presentation of shortness of breath. You could have chest pain. I don't see a lot of patients with scleroderma that have chest pain, but it could happen. Certainly the cough, and even though cough can be from reflux, that's very important. I hope people don't have fainting or near fainting episodes, but again, it's really important that you pay attention to these symptoms. Edema is on your legs. Again, even though that's part of the disease, it's important to pay attention to that. And then increased digital ulcers. You may have more problems with low oxygen, and that may also increase the Raynaud's and have more troubles with digital ulcers. Next. So again, we talked a lot about the shortness of breath, and I really think this is because, we spend a relative short amount of time in your visits with you every 3 months, but we really depend on you to recognize that you're becoming fatigued and more short of breath. And you really need to think about how things have changed between your last visit with your doctor. Can you climb stairs as easily? Can you carry bags? Can you do things as fast or as easy as you did last year? And it's really important that you tell your doctor about any changes that you have in breathing. Next. So we've been doing lung studies and treatment studies in scleroderma a very long time. The very first study we did was with Cytoxan versus placebo, and that showed Cytoxan was better than placebo. The next one we did was with Cytoxan versus mycophenolate mofetil. And again, this was a big study, 142 patients with significant disease. Next. And we were able to show that both the Cytoxan and the mycophenolate had improvement. This is improvement in their lung symptoms as well as their forced vital capacity in the first year after their disease. Unfortunately, after the first year, even with continued mycophenolate, things sort of stabilize, and the Cytoxan, it sort of falls off a little bit. But clearly, we've been very excited and pleased that mycophenolate has been helpful. It clearly also improves symptoms, well-being, as well as improving the skin, and has been pretty much the standard of care for patients with diffuse scleroderma and lung disease for the last 10 years. Next. And the patients that were in Cytoxan group, they had more severe side effects, and they often withdrew from the study. They tended to have more low blood counts and more infections in the Cytoxan group. Patients on the mycophenolate side had some side effects, but generally they could remain on the drug and tolerate it. And surprisingly, even with more than 5 and 10 years of disease on this drug, they've not had excessive complications with infections or anything like that. Sure, there's some infections, but it does not seem to be excessive and doesn't outweigh the benefits that we get from the drug. Next. So African Americans with lung fibrosis, even with the same disease duration, pulmonary function tests are more severe than in African Americans than in Caucasians. We've shown this through our recent abstract that we did out of the Georgetown patients, and yet their responses to mycophenolate were actually the same. And when we looked at the African Americans patients in the scleroderma lung studies, we showed very similar things. Dr. Volkman again did this, and again, she showed slightly lower forced vital capacities to start with, but the same response to mycophenolate. So it's really important that we identify interstitial lung disease in African American as soon as possible and begin them on treatment. Next. So we also now have had 2 new drugs that have been approved over the last 2 years in scleroderma. The Census trial, which is using the drug nintedanib, which is an anti-fibrotic drug that was approved for idiopathic pulmonary fibrosis. This was a global study, the largest study, probably the largest study with scleroderma that we'll ever do. 576 patients. Again, early disease, significant fibrosis, significant abnormalities of their forced vital capacity. Next. And there was a statistically significant less amount of loss in the patients that were on nintedanib compared to those that were on the placebo. This is really, very exciting that there was really a less amount of loss in these patients. Well, half of these patients were on mycophenolate, and there was still, with the nintedanib, there was less loss, even if you were on mycophenolate, compared to those that were not on the drug nintedanib. But it wasn't as statistically prominent, and it's a little hard to know whether it's meaningful. There was no change, unfortunately, with nintedanib, either in the pulmonary symptoms or in any of the scleroderma findings. So it's really only helpful for patients that have significant fibrosis to slow the loss of function in their forced vital capacity. Next. They had a lot of adverse events in this study. This drug has a lot of GI side effects in addition to the GI side effects that scleroderma has. 75% of patients had some diarrhea compared to 31% on placebo, a lot of nausea as well, and some weight loss. But fortunately, most of patients could have the dose adjusted, and only 16% had to withdraw from the study because of side effects. But it still is a challenging drug to take. And I often start patients on the lower dose, the 100 milligrams twice a day, rather than the higher dose to make sure they can tolerate it. And then once they tolerate it, increase it to the higher dose. Next. And then we have the new drug, tocilizumab. Tocilizumab was studied in a phase 3 trial, mostly for skin thickening. It was a double-blind, pure placebo study. It was just placebo or sugar pill versus the tocilizumab. Again, early disease, diffuse skin thickening with inflammation. The CRP is a sign of inflammation and active disease. And the endpoint was the modified Rodnan skin score, which we do for most of our skin trials. Unfortunately, that study was a totally negative study. There was no difference between the modified Rodnan skin score on the patients with tocilizumab and placebo, so it was negative. But next study, when we looked at the forced vital capacity, we found that in these early patients, and again, we're not treating them for their lungs, but if you look at this solid black line, you can see that those patients that were treated with tocilizumab really had very stable pulmonary function over that 1 year, as opposed to those patients that were on placebo in this dark line, this dotted line going down here. That is the cumulative amount of loss of function on the patients that were on placebo. And when you look at the amount here, it was 257 milliliters that those patients on placebo lost, compared to only 20 on the patients who were treated. So for patients with early disease, this has only been studied in patients with early disease and who don't have severe skin thickening, then the use of tocilizumab really may be a very helpful thing, particularly early in the disease. We need to learn more about this drug and its interactions with other drugs and when it may be useful, but certainly it has a role in some patients. Next. So there's also another drug called rituximab, and there have been a bunch of controlled trials with this. This is a really expensive, aggressive immunosuppressive agent that's used also in a lot in cancer therapy. There was a small study that looked pretty promising, but it was too small to be excited about. There was another study out of India that had a 6-month improvement, another one out of Japan that also had an improvement at 6 months. And most recently, the recital study, which is out of England, with one of the foremost pulmonologists leading it, showed improvement in the FVC at 24 weeks, similar to that seen with Cytoxan. We would have liked it to have even better improvement, but the fact that it improved equally as well as Cytoxan, which we know does better than placebo, is a really good sign. And this was done in a patient population, often who had failed some other drugs. And so it may be a drug that we can use for people who aren't responding to other medications. Next. So pulmonary rehab is another really important thing. This was actually modeled after a German study who showed more improvement in exercise than any other drugs had ever done. So it's usually 2 hours, 3 times a week for 12 weeks, and it's including stretching and strengthening, treadmill, improving your endurance, which is really important. So please talk to your doctors about doing a pulmonary exercise program. Next. So the clinical course of scleroderma in African Americans, as we've talked about, has a worse prognosis. It occurs in younger people, more patients with diffuse scleroderma, more severe small bowel, more severe fibrosis, and also the pulmonary hypertension, even though it didn't seem to be that much more common, does occur in younger patients and with diffuse scleroderma. Next. So the question of disparities is always raised when we deal with disease in scleroderma. And part of this, I'm sure, is that there is a delay in some people in the diagnosis. It's harder for African Americans to recognize Raynaud's. It's often confused with lupus. Patients are often treated with lupus medications that really don't work in scleroderma, and thus it is delayed in making the diagnosis of scleroderma manifestations that need to be treated. Next. So the questions are why. So socioeconomic status is always a possibility, and I shared with you, although I matched all my patient populations, I showed a worse outcome in African Americans, but it was related to socioeconomic status, but it was also related to socioeconomic status in Caucasian patients too. So that in general is an effectiveness, but not specifically an explanation that you can deal with causing much more severe disease. Access and coverage and quality of care always is of concern with anyone. General health attitudes and care. Some African Americans, just like some Caucasians, are a little more skeptical of high-powered medicines and vaccines and everything. And so we as physicians have to be sensitive to that and really try to make our case of why it's really important to have aggressive treatment early. There are cultural differences, and And it is really important that we understand some of the concerns African Americans have. But I think there is definitely some disease differences related to the autoantibodies and related to the genetics within African American patients. Next. So these are the antibodies that are in scleroderma. The main three in the United States are anti-RNA polymerase 3, anti-centromere, and anti-SCL70. Anti-centromere is usually the one that's more common in limited cutaneous and without the severe interstitial lung disease. But in these green ones, these are the ones that are the most common ones in African Americans. And these are some of the ones that are most common and associated with some of these severe diseases. Next. So when I looked at this in our Pittsburgh population, these were the three antibodies that were most common in African Americans. U1, and you can see the difference between Caucasians. U3, you can see this difference, and SCL70. Wasn't statistically more, but was certainly more common. Where in Caucasians, the more common antibodies are anti-centromere and RNA polymerase 3. Next. And so when we compared patients that had SCL70 antibody, African Americans versus Caucasians, again, this antibody is associated with severe interstitial lung disease. And even though these were only patients with SCL70, you can see severe pulmonary fibrosis was more common even in those patients that have SCL70 compared to the Caucasian patients. So this antibody, which is more common in African Americans, and within that antibody has more severe fibrosis. Next. The U3-RNP is another antibody that occurs in maybe up to half of some African American populations. They had much more severe GI disease compared to the Caucasians. Again, same antibody, but within the population, the African Americans had more severe disease. Next. So there are genetic differences, and maybe these autoantibodies are part of the different genetic differences. So we're in the midst of doing markers, looking for differences in African Americans that have the disease compared to those that don't. And we have found differences. A lot of them are maybe going to be helpful to sort out sort of pathogenesis, but right now we're just looking at different markers. Next. So this study, Genome Research in African Americans, is called GRASP. It's an NIH study, and we've particularly found genetic differences in HLA relationship, which is really one of the typical associations we find, but we're learning more about what these genetic relationships are. These are not genetic relationships that are specific, handing the disease down to your next generations like sickle cell or anything like that, but they make you at greater risk for having autoimmune diseases. Next. So there are other differences, other diseases, not necessarily autoimmune diseases, but diseases like hypertension and kidney disease are more severe in African Americans and occur earlier, and perhaps scleroderma has some of these features. A major factor in the role of scleroderma is a factor called TGF-beta, and it's been shown that Africans have more TGF-beta than Caucasians, and maybe that contributes to why they have more severe and earlier disease. Again, a possible genetic factor. Next. Dr. Rick Silver, a good friend of mine out of Medical University of South Carolina, has been looking at why lung disease is more common in African Americans. And when he did studies looking at the lung fluids, he identified a factor that was even more common or more abnormal in healthy African Americans. And that factor perhaps contributes to why there's more severe fibrosis. So we're all looking to try to find different factors and different ways we can identify what's going on in scleroderma, particularly in African Americans. Next. So in summary, scleroderma in African Americans is more common and more severe than in Caucasians. There's more muscle, small bowel, pulmonary fibrosis, and earlier and possibly more severe pulmonary hypertension. And health disparities may play a role in the difference in the outcomes, but I think really there are different subsets and different autoantibodies and different genetics in African Americans that really play an important role. And really the key thing here is that we make the diagnosis early and identify what's going on and get everybody treated, because we now at least have various options, at least 3 good options for treating interstitial lung disease. I know Dr. Rick Silver gave a wonderful lecture on pulmonary hypertension. We have 15 different drugs for pulmonary hypertension, and we also have good drugs for skin. So we just have to make the diagnosis early and be aggressive. Thank you. I'm happy to answer any questions. I don't know where the chat is, but if anybody wants to unmute themselves and ask. Where am I supposed to see the chats in here? Angel, can you help me?
Hello, Dr. Steen. Sorry, I was muted.
Okay.
On stage, I'll be happy to pull some questions from the chat and invite a few folks onto the stage. So first, we have a question from Eva Marie Cole. I'll invite her to the stage.
Hi, Dr. Steen. Excellent, informative presentation you've given. I just actually wanted to just make a quick announcement. We have a BIPOC open table starting at 2:15, so we'd love everybody to join us. And would it be possible to get a copy of your PowerPoint?
I usually they print them. I don't know what happened this year. Angel?
Okay.
Yeah, absolutely. Anyone who would like to email the foundation, they can either email info@scleroderma.org or email me at asoto, that's ASOTO, @scleroderma.org. I'd be more than happy to send a PowerPoint copy out to you as a PDF.
And we also have a BIPOC virtual group bi-monthly. It's usually the 3rd Sunday of that month, and our next meeting is September 11th. Thank you, and thank you for your time, Dr. C.
You're welcome.
Thank you, Eva. All right. Our next question is from Zeba. Sorry. Welcome to the stage, Zeba.
Thank you. Hi, Dr. Steen, really enjoyed your presentation.
Thank
My
you.
question is, you were talking about FVC and DLCO. Is one of them more, like, which one should we keep our eye on? Is one more important than the other, or is one giving us a different kind of information?
They do describe different informations. So the forced vital capacity is more related to what we call restrictive disease and scar tissue or fibrosis and interstitial lung disease. The DLCO, particularly when it's an isolated decrease, is more related to pulmonary vascular disease. And years ago, when rheumatologists weren't that adept at reading pulmonary function tests, I established this ratio of the FVC to DLCO. And when that is high, closer to 1.6 or 1.8, that is suggesting more pulmonary vascular disease, because the DLCO can be decreased in both fibrosis and in pulmonary vascular disease. So they're helpful. They're not exclusive, but they're helpful.
Got it. Thank you. Appreciate it.
Thank you, Zeba. Our next question is from Dr. David Leader.
Hi, David.
Hi, here we go. Nice to see you, Dr. Steen. So my question is, did you find a difference in the time to diagnosis from first symptoms? And if so, does that affect the course of the disease?
Yeah, no, we did find a slight decrease in the diagnosis, but many of those were patients that had been previously diagnosed as lupus. And so that interferes with it. When we compared our pulmonary, specifically our pulmonary fibrosis patients, and looked at our African Americans versus the Caucasians, at the same disease duration, the amount of fibrosis was more severe than in the Caucasians patient. Even with the same, it was about an average of 2.8 years of disease. But there are many patients that we don't see until later, and they already have much more severe disease.
Thank you.
You're welcome.
Thank you, Dr. Leder. So we do have a few questions in the chat. The first one being, if I'm an individual that's interested in participating in any future trials that are focused on African American individuals, is there a website or a place or a resource that I need to know of for upcoming trials?
Oh, we would love to have all of you participate in our upcoming clinical trials. I don't think we'll probably have any that are only involving African Americans, but certainly we encourage all of our patients. Probably the best site, there are the National Foundation website has access to some of the clinical trials, the clinicaltrials.gov. There's another website, Scleroderma Clinical Trials Consortium, that doesn't sponsor trials, but we're involved in helping to facilitate a lot of the endpoints and looking at them. And then going to the centers that are near you, the Scleroderma Foundation centers that are centers of excellence. Most of them are where most of the trials are being conducted. And so it is really important. Some of these trials have even had paying people's way to get to them. And so I certainly would consider, that kind of opportunity.
Thank you, Dr. Steen. The next question is, what is a dose of prednisone to treat the inflammatory muscle disease? Do the benefits outweigh the risks in systemic sclerosis renal crisis in a group, given that we are African American and more prone to diffuse disease?
Yeah, those are always very difficult questions. We do have lots of other medications rather than using high-dose prednisone for management of inflammatory muscle disease. And so things like IVIG, things like methotrexate, things like mycophenolate. But sometimes when the muscle disease is so severe, if you can't swallow because your muscles don't work, or you can't walk because your muscles are so weak, sometimes we have to take that risk and monitor and measure blood pressure and take that chance. But it is something that really a scleroderma specialist really needs to weigh all the different risks, usually up to about 10 or 15 milligrams, at least that was the dose that my studies showed, has a pretty low risk of precipitating renal crisis. So those doses can be used reasonably safely, but you still have to monitor the blood pressure closely.
Thank you, Dr. Steen. The next question is there anything for contracted joints, issues related to ligaments and tendons? Can those be fixed or reversed to get more range of motion?
So unfortunately, the surgical intervention with these types of things through hand surgeons, et cetera, is really not very satisfying. We years ago had established that hand surgeons could open up the fingers and fuse them in a sort of a neutral position so that the patients wouldn't have all the risk of having the ulcers on the top of the fingers, but it doesn't give you any flexibility, and that you have to have motion in the back of your hand, the MCPs, to have any effectiveness. Really exercise early, aggressive, using pain medicine if necessary. Many people say, oh, I don't have any pain. And then I start contracting their fingers or raising their arms and they have pain. And you really have to get all your muscles and joints moving. And that's really important early on. And I can honestly say that when a patient is very sort of religious about doing this, and they have wonderful therapists that work with them, do hands-on therapy, it really can make a big difference. It may not be able to totally prevent some contractures, but it can lead to a much better outcome than if you don't do that. But it really most effectively is done early in the disease and when there's still an ability to have the movement. Once the contractures are very fixed, it's very hard to overcome them.
Thank you, Dr. Steen. The next question is there a way to strengthen your throat muscles to improve swallowing?
So the swallowing difficulty in scleroderma is mostly in the lower esophageal. So the upper esophageal from your throat and in your pharynx is not the kind of scleroderma dysfunction in the esophagus. This is more related to myopathy, to scar tissue in your mouth and your throat. And again, exercises are the best things. I have many patients that have seen speech therapists who help them with, again, doing exercises and swallowing to teach you how to make sure that you swallow and don't aspirate. Dr. Janet Poole has been working on mouth exercises for years. Way back when she was with me in Pittsburgh, we did studies doing that, and they can make a big difference. But the lower esophageal sphincter, which is the biggest problem for most scleroderma as far as causing the reflux and the heartburn, I'm not sure there's any exercises. And unfortunately, all of our motility drugs have ended up having so many side effects that we really haven't been successful at using them for improving the motility in scleroderma GI problems.
Thank you very much, Dr. Steen, for that wonderful presentation. Do you have any parting comments for our attendees today?
Well, I hope you've had a wonderful weekend. This is, I think, I really wish we could all be in person, but hopefully next year, where it's warm in Orlando, we'll be able to be together. And I'm here, and my email's around someplace. If anybody has any particular questions or anything, I'm always glad to answer them.
Thank you very much, Dr. Steen. I hope that everyone enjoys the rest of their conference. Take care and have a wonderful day.
Okay, bye-bye.